I'm Mickey Chopra. I'm the Chief of Health at UNICEF in New York. I want to start with the good news. The good news is that we're saving far more lives than we've ever saved before. In 1990, for example, about 40,000 kids were dying every day. Now we're down to about 20,000. So we're saving 20,000 lives a year, a day, more than we did before. And it's not just in China and Asian countries, but it's also in Africa. Every year we're saving millions more lives than we've ever saved before. So that's an amazing achievement. I think sometimes we forget how much progress we've made. And also in countries such as Malawi, Nepal, Ethiopia, countries where we've not seen significant socio-economic development or changes, and yet we've halved the mortality rate for children in particular. So this shows that we have the interventions, we have the technology to save most lives. And in fact, the recent Lancet papers are showing that if we just implemented technologies and interventions that we already have and reach the kids who need them, we would reduce by a further 2/3 the number of children dying every year. So that's for children. Obviously the challenge for women and maternal health is a bit more difficult, mostly because most maternal deaths are unpredictable. They happen during labor, during giving birth, and they also require more sophisticated interventions to stop, for example, bleeding during delivery or severe infection following delivery. So that has been more difficult to address. But once again, there are many countries where mortality rates for maternal deaths have fallen significantly, and across the world they've fallen by 1/3 in the last 10 years already. So once again, we have a lot of the knowledge, we have a lot of the data, and what's been lacking in these things is often the money and the resources. But also what we're finding now is that progress needs to be speeded up if we're going to get to the MDGs. And the critical thing here is going to be addressing inequities. Our analysis at UNICEF is showing that in many countries that are making progress, it's the rural, urban, middle class classes who are taking up a lot of these new interventions, are really gaining from these extra interventions, whereas quite often remote, vulnerable communities are being left further and further behind. So out of 24 countries, for example, that have made the most progress in child survival, 16 of them have actually widened disparities between the richest and the poorest, and in the majority of those countries by more than 10 percentage points, the difference between the richest and the poorest. So what we're getting to is a 2 or 3 level world where a group of people and populations are really benefiting from new technologies, from new vaccinations, from better antibiotics, but a larger and larger group are being left further and further behind. So the key challenge as we move forward, and if we want to continue to make progress and accelerate progress, will be how do we get services and interventions to the poorest? How do we stop making them wait till everybody else has them before it reaches them? And this is what I think is going to be the critical challenge on the way forward, and this is something that UNICEF is now focusing its whole energy on. The ways in which we're doing this is to better measure and analyze the problems and challenges. Why do poor people, vulnerable communities not get these services? And secondly is to look at innovations and better ways of reaching them. They can be through, for example, using community health workers instead of doctors and nurses. It could be through giving financial incentives for poor people to use services. It could be through empowerment and mobilization activities to make health services more accountable to the local poor communities. Because many times, especially in the larger countries, it's not a lack of money, but it's a lack of responsibility and accountability of health workers and managers to the local poor communities. The other big step change that's going to be required is to be more aware of the other causes of death and mortality beyond the immediate ones. In other words, looking at issues of malnutrition. Almost 1 in 3 childhood deaths is attributable to malnutrition. The child is undernourished. Similarly, with women's empowerment and gender inequalities, a lot of maternal deaths and child deaths are due to lack of empowerment and poor education of women in particular. And once again, we have the evidence showing that if you address that, you could reduce maternal and child mortality quite substantially. So these are going to be the new challenges moving forward. If we're going to get to the MDGs in the next 5 years, we're going to have to not do business as usual, but focusing on the poorest, focusing on women in particular, and address some of these more critical challenges. The MDGs have been great in the way of setting targets and helping us to focus on achievements. But one of the criticisms has been that it hasn't had an equity lens to it. So it's always been about averages and about getting progress for the whole. And so what we suspect is happening is that countries and policymakers and politicians, as well as managers, obviously trying to get to the people who they can get to the easiest, the quickest. So it means those living near roads and health centres and so forth. So by focusing in on averages, you can reach an average goal by getting the top half to get more and more interventions and leaving the bottom half further apart. So there are many ways you can get to an average. So what we're finding with our analysis is that the same groups are getting multiple interventions, and groups that have been left behind are getting very little. So the other side of the coin is that out of the 24 countries, I said 16 had widened disparities, but 8 have actually narrowed disparities while still making really good progress towards the MDGs. And there are examples such as Malawi, Ethiopia, Nepal, even Eritrea. And these are, and the common thing across these countries is, one is that they've explicitly understood the challenge of reaching the poorest, and have tried to address it through, for example, in Ethiopia, they're trained 40,000 community health workers now to provide treatment for the diagnosis and treatment for malaria, and most recently pneumonia. Because don't forget, diarrhea, pneumonia, malaria kill the majority of children, but yet only about a third of children in Africa get treated for malaria, pneumonia or diarrhea. So there's a huge gap between the need and the demand for these things, supply of these things. And these countries have really explicitly taken a focus on reaching the poorest as quickly as they can. At the same time, they've also understood of working on sanitation and hygiene behavior, and also supporting critical things like breastfeeding and better weaning as well. I think it's really, this is a golden opportunity for us to make a big difference to women and children, especially the poorest women and children. I think everybody has a role to play, and I think in particular students and faculty at places like universities and in Canada and other places can play a really important role, because right now there's a lot of pressure on governments to cut funding, cut foreign aid. There's a lot of criticism of foreign aid. And I think it's really important for students first to understand when aid works and when it doesn't work, but to also then educate and mobilize around effective interventions and effective aid, and not to cut on those things, because then it would, I think the world we're faced will be far more dangerous than the one we have right now. So I think now more than ever is a time for people to get involved and to really understand the issues and understand good practices and what makes good practices, and really try and motivate to get that done.